Welcome everybody to Fall 2023 South Midi Medical School. There are the social media tags there. You can always go to DelawareMiniMed.org to see the previous presentations. Last week, while there was a PowerPoint, it was very short and we chose not to post the PowerPoint. So it's just the video that you can refer back to. About the program, I think you all probably know this by heart right now. Just remember there's no continuing medical education, no CME, no CE, no CEU. However, those of you who do attend all 6 sessions get a signed certificate. Less than 6 sessions, either you can make it up in the spring session, or you can do a self-signed certificate for the number of sessions that you attended. Program goals: enhancing health literacy, getting you middle, junior, and high school students and undergrads exposed to not only different types of medicine, but different types of providers who serve within medicine. Sharing career pathways, and then encouraging a dialogue between you and the presenter, and we'll get to that through the Q&A after the presentation is over. There's Delaware Youth Medical Academy. If you finish a total of 6 sessions, it could be in one series or between series, then you can write a reflection paper and you can become a member of the Delaware Youth Medical Academy. We're not going to tell you what the reflection paper is going to be about until next week. Housekeeping tips: remember, this is a Zoom webinar. That's why you can't see each other. Only Christy, the presenter, and I can see your names. All questions will be addressed, some by staff, others by the presenter at the end. You do need to stay through the entire presentation, but once the official presentation is over, then you can leave. But as always, some of the really good stuff happens in the Q&A. Today, we are at understanding the roles and responsibilities of hospice and palliative care. And I will turn it over to Christy to introduce this evening's speaker. Christy.
Great, thanks, Tim. I wanted to introduce Monet Henry from Delaware Hospice. Thank you, Monet, for joining us tonight. We greatly appreciate you giving us some time. Monet is the current Associate Director of Admissions for Delaware Hospice. She received her nursing degree from Del Tech Community College and has her certification in hospice and palliative care nursing from PSI Services, as well as her certified dementia practitioner designation from the National Council of Certified Dementia Practitioners. Her experience includes medical surgical nursing, hospice and palliative care nursing, and nurse management. So Monet, thank you again for joining us.
Thank you for having me. I'm honored, truly am. Thank you so much for taking the time to allow me to speak to everyone. Hospice and palliative is truly a passion of mine. And it's something that I know that I didn't get exposed to in school. I learned about it later after I started working. So to be able to express it to everyone and to express my joy of it is just an honor. So I'm going to share my screen.
Yep, you've got it.
Perfect. All right. So again, one of the big things that we say in hospice is why hospice, why now? So I thought that would be the perfect title for this presentation of why hospice. Again, I have my dementia certification as well as I am hospice and palliative certified. So I've been a nurse since January of 2018. I started at Bay Health Hospital, started as a med-surg nurse there. That is where I got exposed to hospice. My floor, we kind of took a little bit of everything. Med-surg, step down, ICU, but we also took hospice patients. And so when they were in the hospital receiving hospice care, it was called GIP. And that is where I first found my love for hospice. So I've exclusively done hospice since 2019. I started with a company called, at the time, Seasons, now Accent Care, and kind of continue to have my love for hospice. I've done different things within hospice, but keep falling back in love with admissions and staying there. So I've been an admission nurse, a nurse liaison, an admissions nurse manager, and now I'm an associate director for admissions at Delaware Hospice. As I said, I am hospice certified. I got that this year. And then also my certified dementia practitioner in August. So being hospice certified and dementia certified, I make a point to keep up with things that are changing. Hospice has changed since I started, let alone since hospice started. So I always make sure I'm in tune of what's happening. So why hospice? Our ultimate goal is to make sure that the patient is getting the quality of life. A lot of people hear hospice and still have that misconception that that means they're going to be passing within days or hours, and that's no longer the case. Medicare has the requirement that says 6 months or less, but even that isn't necessarily the case. If they have a prognosis, that means they'll be passing within 6 months or less. If their disease continue to go down that course, they're appropriate for hospice. That doesn't necessarily mean that at month 6, we're going to take them off of services. If they continue to decline, continue to show that they're appropriate, we will continue to keep them onto services. Our goal is to make sure however long they have, it's lived to the fullest and the way they want to do it. I always say our goal is to provide dignity to the patient. What is it that you would like your last days to look like? Do you want to continue to get lab works and blood draws and treatments and radiation? If so, that's fine. But hospice is when we're more so gearing towards comfort, where we're looking to just keep you comfortable. Maybe it's you want to eat your favorite ice cream or you want to see the beach one more time, which we've done has been a beautiful thing. So we're honoring the wishes of the patient and the family. What is it that they want to do? What is it that they want out of life? And living each day to the fullest, however long that may be. So as I said, I work for a company currently called Delaware Hospice. We have several programs. I've wanted to work for Delaware Hospice since I left Bay Health because of the amazing things that I knew that they did, and they continue to do so. So we do hospice, palliative, and transitions. We also do pediatric hospice called Bug. Looks quite a bit different from adult hospice, but it is one of the programs we offer. New Hope is our child and adolescent grieving program, bereavement program. They do Camp New Hope. They do beautiful programs at either Lums Pond or at Killens Pond. We have a bereavement team for adults. We are Joint Commission accredited. We are level 4. We honor vets working on our level 5. We're part of a Delaware Quality of Life Coalition and also part of Quality Connections. At Delaware Hospice, we have 2 inpatient centers, one in Milford and one in Wilmington, and I'll talk more about those later. So palliative versus hospice, like I said, my company, we do both. Just a little bit of a different goal set depending on which program you're on, but the goal is always comfort. With hospice, though, we're no longer doing aggressive treatments. So let's say someone comes onto services and they have cancer and they decide that they don't want to continue treatment. It would be more appropriate for them to come onto services under hospice. Our goal is to manage symptoms under hospice. At that point, we're no longer doing curative measures. We are just making sure that you're comfortable, you're with your family, you get to do things the way you want to do. Whereas with palliative, you can continue those aggressive treatments. So someone can come onto palliative services and decide that they want to continue chemo and want to continue radiation. They are allowed to do that under palliative. Again, still managing an uncontrolled symptom, but they are still seeking a cure for their disease. So with hospice, no longer seeking a cure, managing symptoms, quality of life, not quantity. With palliative, they can continue to do those curative things. So how does hospice work? So hospice and palliative, we start off with the referral, then the admission team goes out. What our biggest goal is and what we try to tell people is to reach out to hospice sooner rather than later. Even if you feel maybe it's a little bit too early, maybe we can bring you onto palliative. Maybe we can just start building a relationship with you. Because what we want to do is to build that rapport, build that trust with the family. A lot of these families reach out to us even after their loved one has passed because we've just built that relationship and that trust and help them in a situation that is, unfortunately, all of us go through at some point, but still is so uncertain. It's still a very hard thing to go through. And so they come to us to help with them navigate that. And then with bereavement, they get 13 months of bereavement after their loved one has passed. With palliative, again, they receive a referral. We go out and admit. With our palliative program, we're looking to manage some type of uncontrolled symptom. So maybe they have increased edema, increased pain, shortness of breath, anxiety. That would be what our nurse practitioners in the palliative program would be working to manage. The biggest thing with that is us, again, building that relationship, but with the intent, if it's appropriate, to transition them onto to hospice at a certain point. If they decide that they no longer want to continue treatment or continue their treatment has stopped at that point, we would have that conversation of bringing them onto hospice if appropriate. Again, wanted to talk about our centers. So we have one in Milford, DHC, and then we also have one at St. Francis. There, when someone goes to the center, they are managing an uncontrolled symptom. Unlike with palliative, this is short term though. So let's say someone has some uncontrolled pain, maybe we need to put them on a morphine drip. Maybe our doctors need to figure out what pain regimen kind of works for them. Something that maybe we can't do in the home, and it would be better to do it on our unit with a little bit more tools. So they'll come to our center for that. We also offer respite at our centers. Respite is just if the family's burned out, they need a break, maybe they're going on vacation. They get 5 days paid by Medicare for respite. Any days beyond that, it's something that we would have to discuss and figure out if that's something that they would like and how we go about getting that coordinated. Not to say that they can't be more than 5 days though. The thing with our center, the biggest thing with our center is it's only for patients who are on hospice. Our center is not for those on palliative services. So caring for someone on hospice or palliative, we need to find that primary diagnosis. What is it, the diagnosis that we're looking at that will map out our care plan? It will map out how we care for this patient and how we address their needs. Not to say if they don't have other diagnosis or an infection comes up, we wouldn't address those things. But our main focus and our drive is that primary diagnosis. We look at the patient as a whole, absolutely. But what is it, the symptoms that we are looking for with this diagnosis so that we can address them accordingly and then also prepare our families. What's the goal of the patient and family? We often say goals of care and bringing back to that why hospice, why now? Maybe they've had this diagnosis for a while. What has brought them to palliative or hospice at this point? What's happening right now that the family says, this is what we need. This is what we're looking for. On those same lines of the goal, there's times where, so I know I brought up earlier about curative measures. For example, if someone is getting radiation treatment and maybe they have 4 or 5 more sessions, maybe we can have a conversation about continuing those 4 or 5 sessions of radiation while they're on hospice with the intent that once those are completed, there wouldn't be more that come after that. Or I've seen several times families are just looking to try and get to someone's graduation, or they're trying to get to a wedding, or they want to walk someone down the aisle. What is the goal of the family? What are we trying to reach? Maybe it's not even that. Maybe the goal is just for them to be comfortable. Maybe it's the goal of so I can sit on the porch. We had a family not too long ago come out of the hospital, and he knew that once he got home, he wouldn't be able to leave anymore because it's just of his decline. Not something that a hospice restriction, but just because of his decline, he knew he wouldn't be able to get out of the house anymore. So he wanted to see the ocean one more time. So we asked our ambulance company if they could stop him by the ocean before they took him home. He was able to sit there for, I believe they did 2 hours, and he just sat and looked at the ocean. Wasn't in pain. We made sure he was comfortable, but he got to sit and look at the ocean. His daughter was on the ambulance ride with him, and they sat there. And his son was there as well. So things like that. A lot of people, when I say goal, a lot of people are thinking, well, I just want to be able to not be in pain. Sometimes it's a little bit more than that. And if we can make it happen, we definitely will. Circling back to what matters to them. What is it? What matters to them? Is it their family? Is it their favorite TV show? Is it their dog? What is it that we want to know more than just that primary diagnosis? What about you? What were you prior to this diagnosis changing your life? Again, as I've said, is there a symptom that we need to manage? Are there medications that need to be discontinued or adjusted? So a lot of times when patients come onto services with us, we look at their med list. I know patients tend to have all the vitamins and the cholesterol medications. At this point, our intent is to make sure that your symptoms are managed. We aren't really necessarily worried about what your cholesterol levels look like, because if you want to eat something really fatty and greasy, you go for it and you enjoy it. That is where we are at this point, even with palliative, but more so with hospice. So there's times that maybe we discontinue a vitamin, maybe we can discontinue that fish oil or that Lipitor, just depending on where we're at. Not to say that when someone comes on to services, the goal is to remove all their medications. Some families just aren't ready for that just yet, which is okay. We continue to work with them as they continue to become comfortable and trust us and realize that we mean no harm, and trying to just educate, continuing to educate every single visit, every single phone call. They realize that, yeah, let's go ahead and discontinue these meds. There's times that towards the end, we may just have comfort meds. There's a whole set that we have called a care kit, but the go-to medications that we typically use is morphine and Ativan. I know a lot of people hear morphine and there's a story that happened to a loved one behind that, when in reality, it may have just been where they were in that disease process, and the morphine allowed them to finally relax and settle instead of that drive and that continued fighting that they're in. But morphine is good for shortness of breath. It's great for pain. Allows the body to finally relax and take in and the good oxygen, allow them to stop hyperventilating from the pain or whatever the case may be. And then we also, if we do those things in the home and realize, this isn't enough, maybe we do need to have that conversation about them being inpatient level of care. As I had said, my first love for hospice was finding hospice on a med surg floor where we did GIP admissions. So inpatient could be at our center or it could be at the hospital. And we GIP them there a lot of times. So I have 4 nurse liaisons. Their primary roles are to be at the hospital. They have those conversations with the nurse case managers, with families, with doctors, with the palliative program. Here's what we offer. Here's how we can step into this and help this patient. And a lot of times those patients start their hospice, their services, they're at the hospital, and they're called GIP level of care, that unmanaged symptom, or we take them over to the center. Anyone have any questions?
All righty, and we're back. Okay, questions are starting to come in. Hold on for a second here. Okay, if you want to stop sharing your screen.
Yep.
All right, very good. Lakia, yes, running a little bit behind. Will you still get credit? Yes, you will. Okay. How do hospice workers deal with the incoming grief that came with the job?
So a lot of us, we support each other. The team, we all come into this role understanding what it is, but then there are some that are new to that. I make a point to touch base with my team and make sure that they're okay, especially after a tough case. Especially we realize that with hospice, the end ultimately is passing, but there's times that it happens in a way that we were not prepared for, we were not aware of. I know myself as well as the other directors are good about debriefing, making sure our staff's okay, talking to them beyond hospice and beyond work. Are you okay? I know that was a rough one. And just that open communication that we have with each other. Our bereavement program, they are amazing. Yes, they help the families, but there's times that sometimes we've had to go to them because this was a really rough one. I'm not okay. Can I talk to you? And they've been good about supporting us in that. And so it's just building that relationship with everyone in the organization, because the amazing thing about Delaware Hospice is, hospice in general, for the most part, someone has done that role, has been in that spot in some aspect, some way, shape, or form. And so they understand what you're saying. And we speak with each other.
All righty. Haley asked twice, so she must really want to know, how much schooling did you take to become what you are today.
So I went to Del Tech Community College. I have my associates. I do think it's a great idea to have your bachelor's and master's, but I only have my associates. And I am a firm believer that your experience in doing things is a lot more. As I said in the beginning, I didn't get to learn much about hospice in nursing school. We often say we have the labor and delivery course, but no one gives us the hospice and palliative course in nursing school, even though both of those things happen to you in life. So I learned more so from experience in doing it.
Amen. So I think you just answered what kind of degree would you recommend to have when entering the hospice field. So I think we got that one done. Can you talk more about respite care, who it's for, and what does it actually mean?
Sure. So respite, it's a benefit that is allowed to all patients. They are allowed 5 days paid by Medicare to allow it's more so for the caregiver to get a break. If they're a bit burned out, again, maybe they have a vacation coming up, we will look at a nursing home. We'll use one of our facilities, one of our centers, and the patient will go there for 5 days. They'll continue to be on hospice, continue to get care. It's just that the family is no longer the main caregiver. That nursing home or us are that main caregiver so that that family can take a break.
Does respite care ever happen in place for hospices or for patients who are in home hospice?
Not typically. I know that there are some people that kind of do it with like maybe a continuous care if there's like an unmanaged symptom, but typically we take them, they go somewhere else for respite.
Gotcha. Talk to us about how hospice allows for volunteers interacting with patients.
Excellent question. We have several volunteers. I was not aware until recently how many volunteers we have. We have hundreds of volunteers, and it doesn't necessarily mean that you have to give direct patient care. But those who want to do that, we have patients that they will sit with the patient. A lot of times it's that companionship. We have a lot of patients that just want to talk to someone. And the nurses give the time that they have, but there's also their other caseload and their other crisis and phone calls that come in. So that's when we tap in the volunteers and they just sit with them and they build their own little unique relationship, and it's beautiful. Our volunteers have come in a huge way recently at our centers. When we were opening our St. Francis Center, they would always bake cookies. And so you could smell fresh baked cookies throughout the center. They knit blankets, they have the pillows, they help with our memory bears. Volunteers are huge. Beyond Medicare saying we need them, and they are just absolutely amazing. It's an amazing group too.
Great. So going back to mental health and the impact of being a hospice provider, how do you manage that?
That's a great question. So I rely heavily on my family. Knowing when it's time to cut off and decompress. Whether I love swimming, so whether it's swimming, being with family, it makes you so much more appreciative for what you have, and just holding tight to that and holding on close to those around you, but definitely knowing when it's okay to cut off and building a relationship versus crossing those boundaries.
Gotcha. So then related to that, how many hours do you or someone in your type of position typically work a week, and within a range, what's the compensation like?
So what's on my time card is 8:30 to 8 to 4, 8 a.m. to 4:30. So typical, just 40 hours. Because of projects that I volunteer to take on, things that I am passionate about, and things that Delaware Hospice is doing, I do work more than that. But again, knowing my cutoff, and my boss and my team is very respectful of those things. Salary range depends if you're with a profit or a nonprofit. I've worked for both and genuinely enjoy nonprofit. The salary is different from that, but I genuinely love it and would not change it for a world. So anywhere from, I'd say 90 to 120, depending on, again, nonprofit or profit.
I'm answering one of the questions was about what is the work-life balance like, and I always refer back to it depends on the individual.
Very much so.
And
Very
how
much so.
it depends on how you manage your work-life balance.
Correct.
Some people like me, not so good. Yeah, anyway. I'm dying to know the question of this because I didn't hear you say it, but can you talk a little bit more about GIP? GIP.
Yeah, absolutely. So that was, like I said, that's where I got exposed to hospice to begin with. So GIP level of care is when patients who are being taken care of on hospice in the hospital, or maybe they are, because we've done GIP sometimes in our nursing facilities, but that's a different thing. But the intent is, again, that uncontrolled symptom that we're managing, and they are in the hospital, or maybe they are at our center where they're GIP. So if someone has uncontrolled pain, they've gotten multiple doses of morphine and it's not cutting it. Or someone has shortness of breath and they're on a machine called high flow and that's still not cutting it. That's when we step in. Maybe there's some things that we can look at differently. Are there some adjustments we can make? Does that person on high flow, maybe they need a morphine drip to kind of relax them a little bit and allow them to breathe a bit better. But GIP, we're managing that that uncontrollable symptom either in the hospital, at our center, or in rare occasions at a nursing facility.
So that's general inpatient care.
Yes.
GIP.
Yep.
Yeah, I got it. Sometimes it's just is palliative care available to family members living in assisted living?
Yes. So it's available for assisted living. We are going to be doing more so in skilled nursing homes as well, but home, wherever you call home.
Alrighty. For those of you who are asking about how would you sign up to volunteer, there are a number of hospices in Delaware. I'll research a quick list and whatnot, and I'll put it in the chat. So, Krista, I'm going to leave Tabitha's question open. So you could go to DelawareHospice.com or Seasons Hospice or Heartland Hospice,
Yep.
.org, and go to the volunteer link and whatnot. So a question that I would like you to tackle, don't hate me. We live in a culture where addiction is a big topic, and yet we're talking about pain management. Can you talk to us a little bit about the thinking, the ethics, how you all navigate that somebody's only got X amount of time to live and you want them to live as comfortably as possible, and yet the dosages, you know where I'm going.
I absolutely do. So I've run into that quite a few times. I wish I could say that every single time we're able to handle it perfectly. But there are those times where tolerance level is at a level that we try our best to address, but also keeping in mind that pain isn't always a physical thing. Pain could be someone's emotional pain. Pain could be someone's physical pain. They present it as the physical pain always, and needing a medication that is meant for physical pain to address it. But there's a lot of times that it's more than just physical pain. So I have always said to my patients, be honest with me regarding the medications that you use, whether prescribed or not. And all it does, I'm not going to report you. I just need to know so that I am dosing you properly and that I make sure you get your needs addressed properly. The medical field in general, we all have to treat someone as if they were our loved one and are the president, making sure they get the care that they need and deserve. And sometimes, most of the times, with those who have an addiction, we have to get a little bit creative. It's not the typical, let's just increase the morphine. Let's just add a PRN oxycodone. That rarely is the case. There's other things that we need to address, and sometimes it's pulling in the social worker to have some conversations with them and address those things rather than just increasing pain meds over and over and over again.
Right. And sort of related to that, and this gets into the sort of the subtlety of the very close to the end of life. Can you talk to us about how, I believe it is, morphine actually aids with the experience of a patient feeling breathless?
Yes. Yep. That is a barrier that every time morphine comes up, we have to explain and express to families that it's not just for pain. A lot of families say, well, we don't need morphine. They're not in pain. But what it does is it helps that person to relax. It relaxes the respiratory system. Obviously, we're not wanting to go to the point of relaxing it completely, but it allows them to settle. It allows that hyperventilating to relax. They can breathe, take in oxygen. Sometimes someone who was on maybe 5 or 6 liters, we can knock it down to 2 because they're getting some better doses of morphine and breathing a bit better and relaxed a bit better. A lot of times that hyperventilation is that fear of passing in general. And then the restlessness and the terminal agitation that comes with that. And morphine allows us to address those things as well as allow them to be able to breathe a bit easier.
Gotcha. All right, this is a paragraph. I shadowed an oncologist once, and she had to make a couple of phone calls to the patient's family saying that they needed hospice, and there was nothing more they, I guess, curatively, preventively could do. The patient's family got mad and said they would not turn to hospice because they didn't want to give up. How do you deal with such cases?
Great question. I remember I met with a family when I was a nurse liaison for 3 days for probably 2 to 3 hours every single day to explain to them that hospice is not giving up. I always tell people that hospice is another option. Hospice is another route to go if you choose to go that route. As I said, I'm always presented as quality of life. It is not those days to hours anymore that it used to be. We've had patients on for 4 and 5 years. But the intent is to make sure whatever time you have left, it's you living it to the fullest. It's you living it as comfortably as you possibly can be. A lot of families, it's multiple meetings with them. I can't always get them to change that mindset that's constantly in our head in general, that this is not the end. This doesn't mean you're giving up and you're stopping everything. A lot of people also feel that with hospice, if someone gets a UTI, we won't give them antibiotics. We'll have them suffer with the UTI. That's not the case either. So a lot of those patients a lot of the families and patients that feel that hospice is giving up, it's a lot, I think a lot of conversation of just getting over those myths and misconceptions of hospice opens their mind up a little bit.
Right. Here's a good question. How do you navigate the delicate balance of providing essential care for individuals with dementia in hospice palliative settings while actively fostering and enhancing their capacity for meaningful social interactions? Recognize the potential for isolation within palliative care context. Wow.
Excellent question. So more, as of tomorrow will be more, but as of right now, I believe it's 76 of our practitioners are dementia certified. Whether that we took the class, all took a test, and navigating ways of the number one thing, making sure that patients aren't isolated, making sure that although their interactions with us may not be the same that it would be with someone else, making sure that those interactions are still meaningful and that they're purposeful and still give them dignity. So I always say the more people we can get in front of them when appropriate, we definitely do. Volunteers being with our patients who have dementia, maybe a CNA stays a little longer if the nurse can stay longer. Pulling in the family too, because a lot of times families are aware that the person in front of them is not who they always knew, but it doesn't mean you stay away. That doesn't mean you avoid. So pulling in families and helping them to understand your loved one may not fully understand or remember who you are, but be around them. You make them laugh, bring up something that they remember when they were children, because a lot of times they remember the former things instead of the more recent things. So we always have their books, photo albums, bringing those things in the forefront, and whatever time period, whatever time frame they are in, we go in there with them. We don't always want to reorient them if it's not appropriate, because a lot of times that just causes more frustration and just has them shut down completely. So we just go wherever they are with them,
Right.
but always interacting.
And another thing with all of us having access to technology and the internet, if you know when they were born and you go 10, 15, 20 years ahead, find the music that
Yes.
they would have listened to as a kid or as a young
Yep.
adult or as an adult, that can really be breakthrough moments.
Yep.
Um,
Absolutely.
without generalizing too much, can you walk us through the last 24 hours of somebody's life?
Sure. Um, so it depends on usually the diagnosis. But for the most part, what tends to happen, not always are you unresponsive. Does that usually happen? Yes, but not always is someone unresponsive at the end of life. A lot of times the confusion happens. 9 times out of 10, you see that kind of shortness of breath or that apnea, the gasping or the pauses in breathing. Um, our intent is a lot of people, I remember a family had said, you giving medications is like euthanizing an animal. And I explained to them that these symptoms of passing happen. The medications are meant to make them not be as unpleasant to family. These things are going to happen, but I would like this process to look a bit better to the family. So when those apneas and gasping of air, give them morphine. Some patients get the dry mouth, and so we make sure that they have the wipes, or we'll have like the little mouth swabs. I've dipped them in like orange juice for people so that they can get that too. Some people are usually cognitive enough to realize, oh, something's in my mouth, let me grab that. Some patients may have some swelling. Again, a lot of it is making sure that the nurses see these things, the caregivers see these things. We want to make sure the families don't see them though. So if they're having some swelling, we'll cover them with a blanket. You may hear something called mottling. Families will have like these almost looks like bruising and little not dots, but like spots that will come up on the legs and the extremities. Keeping those things to make sure the family doesn't see those things. And most people will have that hallucinating. They may see loved ones who have passed, reaching out for things that aren't there. Again, it's one of those things you just go there with them. You don't say that's not there. We don't want to cause any further agitation in that process. But heart rate slows. Patient tends, not always, but some tend to be unresponsive. And just having the family around them as they can and as they're able to handle that, having the family with them in that. The unpleasant things tend to happen later on, but in that moment of them passing, we just make sure that they're comfortable with the medications. But again, the big things are that the apnea and sometimes that hallucinating, most of the time hallucinating.
Right, right. Yeah, I've experienced some of that myself
Yeah.
in hospice work. It's meeting them where they are.
Yeah,
Going
absolutely.
along with the journey. Yes, that's
Absolutely.
a good thing. Another question that's not in the chat, but it's something I wanted to tease out. Hospice and organ transplant.
Great question. You absolutely can be an organ donor if you are on hospice. I have been a part of quite a few honor walks, which has been beautiful. But you absolutely can be an organ donor. We have patients that will even donate their bodies to science if they choose to do so. We just need to know those things ahead of time. We get those things coordinated, and that does not change if you are on hospice.
Right. And then when somebody expires, they're dead.
Yes.
Who actually pronounces them?
So they are what's called a DNR, meaning do not resuscitate, no chest compressions are done. The nurse will pronounce. If they are a full code, we go that because you can be a full code on hospice. So we will go the route of the code at the end. If it's determined that the CPR did not work, the physician would pronounce. But for the most part, patients are pronounced by the RN.
Right. Okay. How are nurses protected against violent episodes of dementia patients? I might add, of any patient.
I will say in general, yes, you care for your patient, but also protect yourself. If someone's swinging at you, please avoid those things. But the patients become agitated. They don't always know where they are. They don't always know what's happening around them. I think a lot of us, after a certain point, you get in tune with certain triggers for that patient, and try to avoid those things. But then it might be just a completely off day. And just making sure that you're aware of your surroundings, you're aware of what's around you, what's around them, making sure if you have a patient that you already know is more agitated than usual, being aware of what's around them, what they can grab and what they can reach. Because they are extremely strong. So being aware of that.
Yeah. I've always told people, if you can imagine how strong your little cat or dog can be, just think of how strong a human can be, even
Correct.
when they're in really not very good condition.
Yes.
You never underestimate the reach of the kick.
No.
Human being.
Just stay out of the way.
I say this with love. Is there any additional education that you may need to become a hospice worker outside of your regular nursing background, for instance?
No, it's not required, but I definitely think if it's offered, you should definitely take advantage of it. I think it only helps you and helps you respond to those things, cope with certain things that come up, the relationships that you build while doing those educations. I definitely think take advantage of any webinars, educations that come your way, but required is just your associates. Again, I do recommend going for your bachelor's, and if you can do the programs that allow you to go right to a bachelor's, I do recommend that, but not required.
Okay, so let's imagine that you're in high school, so 10th to 12th grade. Are there any classes that people perhaps should be considering taking right now to prepare them for downstream if this was a particular type of care that they wanted to pursue?
I say in general, anything for psychology, any type of human relationships, because it ultimately comes down to that. Those basic human interactions, going back to the basics, anything to just tune in and hone in on human interactions and relationship building, because it's ultimately what it comes down to, especially for hospice. We're coming into a situation that is uncertain for this family in general. It's a very vulnerable situation. So being able to knowing how to build those relationships, definitely. And if there's any CNA programs that are offered, I definitely recommend that as well. Anatomy, anything like that.
Right. And I put the link for everybody in about different hospice programs, volunteer. Did that pop up for folks, Christy? Okay, I'll go back and find that. I just realized I put it in the Q&A, not in the chat. Okay, silly me. Our anonymous attendee asked another platinum question. Have you encountered any challenges related to public misconceptions about hospice and palliative care for individuals with dementia? How have you addressed these misunderstandings to ensure a more informed and supportive environment for both patients and their families?
Excellent question. We are big about educating our community. That is the only way that we can get in front of people. So we still run into often the misconceptions of hospice and palliative, especially when it comes to dementia patients. Like I said, a lot of people feel that if someone's on hospice, if they get a UTI, because most dementia patients are prone to UTIs, we won't address it. If they get any type of infection, we won't address it. Breaking down those misconceptions of that. That was one of the biggest things in our dementia certification program. Realizing that someone on hospice, there are still things that need to be addressed, especially for dementia patients. So we make a point to educate our community as often as we can, whether that be getting in front of hospitalists, PCPs, social workers, to make sure that they're aware of the benefit of hospice and something that they could be failing to give their patient, and an additional support that they could be giving their patient.
Right. Christy, I'm noticing, I'm putting this in the chat, but I have a feeling that
It just
only
it came
the three of us can see this.
I can share it for you.
Would you please?
Yeah, I can share that. And
I
then I have
don't
a
have,
couple
I don't have
questions too.
permission.
I have a couple questions for you too, Monet.
Sure.
Can you talk about a little bit, you talked about there was adult hospice and there's pediatric. Can you tell what the
Correct.
difference really is?
Sure. So with pediatric hospice, for our program specifically, which I was not aware that it's different for certain programs, but for us specifically, we call them our kiddos. They are allowed to continue aggressive treatment if they choose to. They can go into the hospital and get any type of aggressive treatment that they were receiving for their diagnosis, any aggressive antibiotics, other outside of what we would typically do to address an infection. They continue to proceed as normal. We just have now, they now have that additional support of us and our team. But which, like, again, that is not the case with all programs, which I was not aware of until recently.
And you're talking about a team. So what's the care team look like?
Sure. So they get an RN. The RN comes out. Typically, it's once a week, once every other week. But it's always based on what the patient needs. If the patient needs to be seen more, we come out more. If there is a symptom that's happening, if they're towards the end of life, we definitely come out more frequently. They're also entitled to have a CNA if they would like, anywhere from 2 to 7 days a week. We have the ability right now to do 7 days a week on the weekends for some of our counties, depending on the availability of the CNA. And then a social worker. I always say to families to use a social worker as much or as least as you would like. I think people still think of a social worker and think it's someone trying to take something from them, where in reality, the social worker can help them navigate things in the medical system, in the medical field that they're just not aware of. Insurance is a beast within itself that I still leave to our billing team and social workers because it's not my realm. But the social worker can help them navigate that as well. They also come in they play a really big part when it comes to placement. So we may have families and patients that start off at home, but as they decline, or we may even notice at admission, they're eventually going to need to go into a nursing home because they just need additional support. The social worker gets the applications started for that, reaches out and works with the family on finding a facility for that. And then they also receive a chaplain. Chaplains are non-denominational. And I always like to present them as an additional person to the care team, not necessarily as a preacher or a pastor, an additional person that's there to be someone you can talk to, someone who can help you, and just to have a conversation with. And then we also have our volunteers if someone would like one.
How does that care team prepare a family for what's to come?
So our social workers, they all do, but our social workers and our nurses, they at a certain point, they always team up. But at a certain point, when we see that those signs are a bit more visible, having those conversations with the family a bit more often and explaining to them that these scary things that are happening that they're not used to, that are so beyond our normal, are normal in this instance. We have several pamphlets, programs, groups to kind of help them understand better what's happening with their loved one. But a lot of it doesn't necessarily stop at the end of the visit. Maybe they need to reach out after hours. Maybe the nurse needs to speak with them immediately after the visit, as soon as they've gotten back in their car. But constantly reassuring. I think the biggest thing is reassuring the family that you're doing the right things. You're doing right. They are okay. You're doing a great job. I don't think people always realize how much that means to someone to just simply say you're doing a great job.
Yeah, I agree. Can you talk to us a little bit about transitions? You mentioned transitions program.
So our transitions program is for someone who doesn't necessarily have a medical diagnosis. They don't have a terminal diagnosis, rather. Someone who needs some additional support navigating, maybe helping them find private caregivers. Maybe they need Meals on Wheels in the home. They are a group that I wish more people knew about because they are amazing and they have been huge in patients coming onto palliative or coming onto hospice. But their main thing is helping. It's 2 social workers are a part of it right now. But their main thing is kind of helping you navigate all the additional resources that are available to you that you may not know about. That's where transitions comes into play.
And I would say it almost mimics what, and Tim, you can correct me if I'm wrong, what a community health worker does out in our communities with providing support services to our community members.
Yep.
So, definitely. We have a question that says, how do patients in hospice deal with their emotions of dying soon? Is there any counseling help that is being given to the patient?
Absolutely. So that's another great thing about our social workers. There may be a time that, yes, bereavement tends to be at end of life, but we may see that anticipatory grief and we need to pull someone in a bit sooner. We need to pull our bereavement team in a bit sooner. Talking that out with them. The fear of, I am a huge believer that your mental state affects your physical state. A lot of times, if you aren't in the right mind frame mentally, you can't heal, you can't process, you can't go through a step if you're not there mentally. So just talking it out with the families and the patients specifically, if they're able to participate in that, what are you feeling? What are your fears? What are some concerns that you have? I've seen many patients that the dying process could have been a more pleasant experience had they been more willing to have those open conversations, because there's just fears and misconceptions of the unknown, and just talking that out.
What is the most significant lesson you've gained from your experience in this work?
Oh, that's a great question. There's several. I think just valuing life, not that I didn't before, but realizing life is so extremely precious and can be very fragile. Um, but it shouldn't hold you back from living life. Whatever that looks like for you, whatever you want that to look like, to go after that. We've had patients, we've had families completely rearrange a wedding event so that the loved one can be a part of the wedding and it be in the home. We've renewed vows for couples who are on services. Just taking, it's such a cliche, but stopping and smelling the roses, because life is moving fast. But taking those moments to enjoy life and enjoy your family is huge.
So I'm going to ask this question because I have experience with Delaware Hospice. Talk to me a little bit about, or talk to the group a little bit about how you honor your veterans.
So we are actually a level 4 right now at honoring, we honor vets. We are working towards our level 5. What we do is we identify which branch that they are with. We then do a pinning ceremony, which will bring anyone to tears. We sing the song for their branch. They are presented, we also read a poem. They're presented with a certificate. They're pinned. It's a beautiful thing when another volunteer vet is able to do that. But we all get together. We recently did one. He was World War II vet, I believe. And he loved lemon cookies. And so they made him lemon cookies. They did the pinning ceremony for him. A very stoic, manly man was smiling ear to ear. Everyone was crying. It is such a beautiful thing. It's one thing to say thank you for your service and thank you for that you do. But the We Honor Vets, we've even done it for spouses on that were their spouse was on service. It's just a beautiful, beautiful thing. They get the flag, they get the pin, the certificate. If we can have a musical therapist there, they'll play the song. It's absolutely beautiful.
How many patients do you look at as a hospice worker? I'd say how many patients does a team have?
So the nurse typically has 14 to 18 patients. A team right now is about 100, but like multiple case managers within that program.
And Camp New Hope.
Yes.
I know how wonderful Camp New Hope is. Can you talk a little bit about what the week looks like for those children that are in that camp?
So we actually just had one, and forgive me, the title I believe was Not to Miss a Note or Continue to Have a Song Go, something along those lines. But it was helping kids to realize that yes, this has happened, but continue to play your life song, continue to go on. They have amazing, it's a week full of amazing activities, things that is fun for them, but they don't realize in the same aspect it's helping them with coping skills. Something I think we as adults need to be more open about talking about. But the Camp New Hope, there's the counselors there that are a part of that, and they do crafts, they have the picnics. It's an amazing thing. I was unfortunately wasn't able to be a part of it this year, and I so badly wanted to, but it's a beautiful thing. Our team volunteers for it along with the New Hope staff members, and it doesn't necessarily have to be a child whose family member passed on our services. It can be any child or adolescent that has lost someone and they want to come to our New Hope Camp New Hope program. It's a beautiful, beautiful thing.
I have to say Camp New Hope is fantastic. I had the honor of volunteering there 1 or 2 years myself. I had a daughter that went through Camp New Hope twice.
Okay.
And I think the best part is at the very end, the last day, they put on kind of this show.
Yes.
The kids put on this show with all of their counselors, and everybody gets together, and you can just feel the love and the support in that room for the kids. But they have a great time. They really do. And like you said, they're learning how to grieve while they're having a good time, and they're networking with other children that are experiencing the same thing. So I think it was fantastic.
It's awesome.
Right.
You talked about level 4 and 5. Somebody just wanted to know what's the difference between level 4 and 5.
So another thing that I will admit, the 4 and 5, I don't know all of the requirements, but a certain amount of hours that you have provided to veterans, certain amount of things that you have done for veterans that allows you to be at certain levels. We are working towards level 5, which is the highest level. We're currently level 4, but level 5 is the highest level that there is. And it's a huge, huge honor. It just shows the work and the dedication that we give to vets, allowing us to get to level 5. There's more things that we need to do with veterans, having veterans participate more so in our ceremonies and things along those lines.
Kevin, do you have any other questions?
I think we did it. Thank you very much, Monet.
Absolutely.
Presentation, great Q&A. And to whoever it was that asked the 2 really tough ones, good job.
Awesome.
Good job. Okay, Christy, who do we have up next week?
So we have Colin Burke next week, who will be here to talk to us about the role of physical therapy in healthcare.
All righty. Everyone, until next week, have a great evening. Be good. Thanks. Bye-bye.